Good morning, everyone. I'm Dr. CHYTHANNYA, Senior Lecturer at Department of Oral and Maxillofacial Surgery, Minds. And today I'm going to talk about the surgical removal of mandibular third molar impaction. So, as we all know, the impaction happening because of some kind of hindrance, which is leading to the non-eruption of the tooth into the oral cavity. And the most commonly impacted teeth are mandibular third molars. Mostly because they are late time for eruption. And now we'll go to the major part, which is the surgical removal. So coming to the mandibular third molar impaction. Mandibular third molars are the most commonly impacted teeth. They can be differently classified based on their whether it's a hard tissue or soft tissue impaction. Also can be classified based on the angulation of the tooth, to which comparing with the long axis of your second molar. That can be mesioangular, distoangular, horizontal, vertical, or even transverse pattern. So coming to our first thing, it's always about the incision. When it comes to surgical removal, we need a clear field, and we know the basic principles of surgery includes the visibility, accessibility, and all. So in order to achieve a proper visibility, you need to get a proper flap as well. Flap, as in you have to make a mucoperiosteal flap, which includes the mucosa, the periosteum. And so when you reflect the flap, you will get direct access to the bone, or the tooth in case of soft tissue impactions, so that you will get a direct access to the tooth with limited hindrance, soft tissue hindrance. So usually in case of our mandibular third molar impaction, we use the number 15 PP blade. And there are different types of flap available. We can start from the envelope flap, which is the most easiest flap. There is a limited accessibility using this kind of envelope flap. Basically, you are getting your starting from the ascending ramus, following the center third molar shelf to the distrobuccal surface of second molar. So it's like a linear, curved, mildly curved incision, which is going to open up like an envelope. So your accessibility is going to be limited towards that area alone. The incision extending to the mucobuccal fold of first molar is a second and first molar sulcus incision. So best for linguoangular impactions, as it provides a better visibility in that cases. Linguoangular, as in when the tooth is faced towards the lingual aspect. Then a better or with a clear visibility and all those things are your triangular or bayonet flap, which is envelope incision plus an anterior vertical releasing incision. So when you give an anterior vertical releasing incision, it opens up like a triangle, which is going to give a better accessibility to the site. Then there is Watt's incision, or Watt's incision as we normally call. It is the most accepted and most approved incision used for your third molar impactions. So the incision begins 6.4 mm in the buccal sulcus at the junction of middle and posterior third of second molar, and passes upward to the distal angle of the second molar. Then cervically behind the tooth to midline, its posterior surface taken back laterally to prevent the vessel injury in the retromolar area. Basically, you are starting the incision at the second molar distal line angle side. It is like 6.4 mm in the buccal sulcus. Your depth of anterior releasing incision should be that much. Then you are going with the clavicular incision, which is going through the distal papilla and the whole clavicular aspect of your third molar, if it is visible. And when you reach the distal aspect of the third molar, there has to be in the midpoint, you are starting to give a distobuccal incision. You should not go lingually because it could go to the lingual soft tissues and maybe into the pterygomandibular space, which could lead to the uncontrolled bleeding and damage to the vessels and other things, which has to be avoided. And which is the most commonly given incision for your third molar impactions. And there is a modification to Watt's incision can be present, and it is like a modified Watt's incision is given when there is a deeply impacted or a distoangular impaction, where you need to access a little more bone for the proper access and visibility of your third molar. Or as shown in the case, it is a deeply seated impaction. So just giving an incision from the distal aspect of your second molar will not be enough to access into the same point and do the surgical removal. So you are starting from the first molar's distal aspect instead of the second molar. So getting a wider access to the site. And then there is an L flap which is basically the modification of your triangular flap or biannular flap. So it is basically called paramarginal flap. Just the marginal parts are included. And triangular flap, like we already discussed, it is just when you're opening the flap or when you're reflecting the flap, the surgical site which is visible is going to be a triangular shaped site. In all aspects, the most commonly preferred flap is definitely your Watt's incision. So, coming to our surgical removal. So there are different types of surgical removal. Once you expose the crown or once you expose the bone part which is visible, then we are going to do the bone cutting, which has or bone removal, which can be done in multiple ways, either using your burr, which is the most commonly accepted technique and which is the most easiest in a sense. Then there is your postage stamp method. Then there is your chisel and mallet technique. And in order to start with your bone removal, you have to expose the crown first. Then you are going to identify what is hindering the removal or the complete eruption of the tooth. If it is the nearby tooth or 7 which is hindering, then you might have to go for the cutting of the tooth, which is to be extracted. You have to always be taken into care that the tooth which you are removing can be cut in multiple pieces, but the bone and the nearby teeth or other structures which has to be preserved as much as possible. So starting with the bone burr technique, usually we use number 7 or 8 roundwood or number 702, 703 burrs. And basically you are giving a guttering along the collar aspect, just shown in the just like shown in the image. You are going to give a gutter along the collar aspect of your tooth and relieving its hindrances majorly. So when you give a collar guttering, there is a possibility the tooth could get much more loosened and it will be easier for removal. And especially your cutting has to go till your cervical line. So the tooth removal will be much more easier. Then there is something called postage stamp removal method. Adequate cutting of bone on the buccal aspect of tooth is done in the shape of postage stamp and adequate space for application of elevator is created. So basically, you're going to cut a lot of bone, and then you're going to apply the elevator and elevate it. If it is a mesioangular impaction, you're placing the elevator in the mesial aspect. You're creating a big hole or the in the shape of a postage stamp, and then you're applying the force using an elevator and lifting up the tooth, which is possible on your basic mesioangular or vertical impaction, but will be difficult for your distoangular or a horizontal impaction because of the loss of too much of bone structure. Then the chisel and mallet technique, which is the age-old technique, which is not usually used nowadays, even though it does not cause much heat trauma or frictional trauma to the bone, as much as your bone cut during bullseye creating. It is still a traumatic procedure for the patient. Using a chisel and mallet inside the patient's mouth is a difficult aspect. So you are basically using the smaller size chisel and mallet to create the space to be to enable the tooth to be removed. So basically, just like the is shown in the image, you are going to give a stop cut the anterior to the impacted tooth, which is just distal to the septal. Then towards that, you are giving a horizontal cut as well. So you can see in the first image, there are grainy parallel lines, which are the lines or grains of your bone. And your vertical incision or vertical cut, which is given in the first, is going to limit the spread of your horizontal extension of your cut when you're giving a horizontal cut, like in the third image. So if you are not giving a vertical stop cut, there is a possibility your horizontal cut could extend further anteriorly and create damage to the further bone mandible. Or this technique sensitivity leading to the lesser usage of your chisel and mallet, even though it creates a lesser edema to the patient. Then there is something called lingual split bone techniques. It was introduced by Sir William Kelsey Fry in 1933. And later was described by Terence Welch in 1956. In this case, actually, the mandibular third molar especially, it is done on patients with younger age, that is unerupted or completely impacted molar. It's a more like a prophylactic technique. You are actually elevating the flap, and via lingual aspect, you are making the, just like you are given in the chisel and mallet technique, you are giving a vertical stop cut and then a horizontal cut, then lifting up that part, and then you are elevating and removing the tooth and replacing the further bony window which you have created in the first part. So when you are cutting and replacing this lingual aspect, there is a higher probability you could lead to damage the lingual nerve, which is just lingually placed to the third molar. So especially when it is considered to be done in younger population, there is a higher probability of lingual nerve damage, which has to be avoided. So it's not a very much followed technique unless unnecessary. Then there are modification to lingual split, which was introduced by Lees with minimal periosteal reflection, preservation of fractured lingual plate, length, buccal bone guttering, and everything. But still, a better technique preferred is going to be your basic technique, which after your impacted tooth has been erupted. Then there is lateral trephination technique of Boulder Henry. So it was considered, it is a considered to be a good technique for preservation of preoperative periodontal status of second molar. Basically, this is also a technique which is done before the eruption of your third molar. When it is completely inside the crypt, you are giving an extended S-shape incision, like shown in the image A. and you're reflecting the entire flap, and within that you're going to identify, use your Bordler Henry retractor, then identify the site using a radiograph where the tooth is impacted. Then a round burr is used to find the position of the crypt of the third molar, where the third molar is located. You're going to give a estimated stampage of your third molar crypt, and then you're elevating that part like a window, and you're using your chisel and mallet. You then take elevating the tooth out of the crypt and repositioning the same thing. All the follicular remnants and everything has to be removed clearly to avoid further any kind of cyst formation and pathological formation. And the wound has to be thoroughly irrigated before the closure. Then there is simplified split bone technique, which was given by CJR in 1995. The incision is placed on the buccal side of anterior border of ramus towards the distal aspect of second molar along the buccal junction to its midpoint to reflect the flap, and removal of the buccal bone to expose the height of the contour. So basically, after you're reflecting everything, you're going to give a horizontal bone cut with chisel over the edge of previously placed incision in the PDS space. Then proceed lingually and distally. Then you are going to separate the whole lingual plate by parallel chisel, just like we explained before, and then deliver the tooth via the distal lingual direction. Then after that, we are coming to the coronectomy. Coronectomy is basically the removal of crown in certain scenarios where your roots are very close proximity to the inferior alveolar nerve, or there is a high difficult laceration to the third molar root. In all these scenarios, we have to go for a coronectomy. Coronectomy is basically you're removing the entire crown part, and you're going to pull out the pulp out of the roots retained as well, because you should not retain any kind of pulp tissues back in the root structure, because it could lead to further infections or other problems. It is usually contraindicated in horizontally impacted teeth, teeth with active infection, mobile teeth, non-vital teeth, teeth with periapical pathology, and having pre-existing inferior alveolar nerve and other disturbances. So basically, when your tooth cannot be extracted without damaging the other structures, you have to go for a coronectomy. So after your bone guttering and possible coronectomy or non-coronectomy planning, you have to go for the tooth removal thing. So coming to the tooth removal, where it is majorly depending on the type of impaction on which your tooth is staying, whether it is mesioangular or horizontal or distriangular. Depending on the direction of the tooth in which it is angulated, you have to go for the tooth splitting as well. So the indication for tooth sectioning are tooth impaction, unfavorable root morphology to prevent injury to the adjacent anatomical structures to avoid removal of large amount of bone. And advantages of tooth sectionings are reducing the amount of bone removal, like we said in the before, or limit the bone removal, split the tooth, which has to be removed. Reduce the risk of jaw fracture, less post-operative trismus, and avoidance of damage to the anatomical structures. So coming to the horizontal impaction, you can either go for a current supro-inferior direction sectioning to prevent inferior alveolar canal approximation and other things. And also when another possible technique is you can go for a hemisection. Then you remove the distal aspect of the tooth. Then you split again you have to split the crown portion of the mesial aspect, which is going to be hindered below your 7. It is going to be like this though. You have to remove that particular portion of crown and then separately the root. So just like in the image given, you are going to give a hemisectional cut Then you are removing the distal aspect, then you're giving a cut into the mesial aspects, crown separate, root separate, and you are removing separately your crown and root portion. And in case of mesioangular impaction, again, you can go for a hemisection, or maybe you can go for a small split onto the mesial aspect, which is hindering onto the 7. Then you're going to cut the mesioangular portion. Then once the crown is relieved, you can actually relieve the entire crown and a tooth and take it out. And in case of distoangular, you have to go for a further more damaging or more bone removal. Then after that, you are going for, usually you are not supposed to cut immediately into, do the hemisection for distoangular. You should start with cutting the crown, which is the crown portion, which is hindering with the distoangular or the ramus part. Then once you remove that relieving portion, once you remove that hindering portion, you can easily relieve out the tooth. If you are not relieving that portion, there is a higher probability it will lead to the it will not be easier for the removal of the tooth. And then so that's all for today's class. I guess that's you were able to understand what was happening. Now, thank you for the patient listening. We'll stop sharing the PPT now. So I hope you guys understood.